No problem.
Okay, thank you. So JD, and I hope I'm saying it correctly, you're using the sort of abbreviated term there, is based in Canada. He's a principal investigator in the Knowledge Translation and Health Systems Research Program at the Population Health Research Institute and an associate professor in the Department of Medicine at McMaster's University. He's an interventional cardiologist at Hamilton Health Sciences. I'm not going to say too much more. I do hope that Professor Patricio Lopez Dermilo, who is the scientific director of the Masira Research Institute in Colombia, will be able to join us in not too long a time. But both of these experts were principal investigators on a GACD study, the HOPE-4 project, which was within our first call under the hypertension program. And they're going to tell us a little bit about that activity and about the outcomes and how they are actually influencing and hopefully on the way to create impact. Over to you.
Great. Thank you very much. Is it all right if I share my screen here?
It is, or if you want.
If that works for you, I'm happy to
that works for us. That's fine. Thank you.
Great. Okay. Well, thank you very much for having me present today on behalf of all of my co-authors and co-investigators. There's a large group of us, and particularly Patricio hopefully can join. If not, I can, as mentioned, I can speak on his behalf. But we'd like to talk to you about the HOPE-4 study and kind of just a brief summary, and then kind of move into where it stands today and where we hope to go. And if there's any questions at the end, hopefully we'll have time. So just disclosures, I mean, obviously this was primarily funded by the GACD, and we appreciate that support. Wouldn't have been possible otherwise. We were part of the hypertension call, and just as everybody likely knows, hypertension is the leading cause of cardiovascular disease worldwide. We know there's clear evidence in reducing blood pressure that will reduce cardiovascular disease and mortality. And yet we know that hypertension detection, treatment, and control is very low globally. Just as a point, we know that a combination of 2 or more low-dose medications are more effective and have less side effects than a single high-dose agent. We know that statins reduce cardiovascular disease and hypertension, but their use is very low in this population. And so the combination of blood pressure and LDL lowering has the potential to reduce cardiovascular disease events by greater than 50%. And this was setting the stage for the HOPE-4 study. So really, we set out to improve hypertension and cardio risk factors in people with hypertension within the community. And to do this, we first had to set out and identify the barriers to hypertension management. And so this was a task that started in 2013. And we looked at patient and healthcare providers and their barriers to hypertension awareness, treatment, and control. We then moved on to the health system level and looked to what has been published in the literature to help support us and guide us through this development. We then went specifically into the countries that were involved in our studies. So we had Colombia and Malaysia were our 2 countries that were our core partners in this project. And we did an assessment from the patient to the healthcare provider right through to the health system in Colombia, and we repeated that process in Malaysia. And this was to get the contextual barriers that were preventing this appropriate detection, treatment, and control. We even looked at the legal landscape about these combined pills and how will that work and what can be put out there. Is it possible for generics to make these combination pills? So this was looked into as well. And then we published the odd review article trying to kind of pull this all together and get our thoughts organized. We then went forward and developed a community-based comprehensive intervention, which I'll speak to. And part of this involved a curriculum where we trained lay health workers. And then we went on to our large-scale evaluation, which was a cluster randomized control trial, which tested this implementation of this intervention. So speaking to our intervention, I won't go into the details of the barriers, but as we identified, they're at all 3 levels, and there were some contextual ones depending on the country and the location. But essentially we had a framework for an intervention that we used, and it involved task sharing with non-physician health workers or community health workers. And they were community-based, and they went out and identified and treated hypertension and cardiovascular risk. They were supported by mHealth technologies with tablets, which helped them through counseling and simplified management algorithms. They were all supervised by primary care physicians who would actually provide the prescriptions for the medication. So we didn't change the existing kind of legislation or rules within these countries. We followed as it's already in place, but tried to work around the barriers. We also provided free medications when necessary, so particularly combination antihypertensives, given their evidence and benefit, along with a statin to those that met criteria. And then one thing that we did is we really wanted to involve family and friends in a more formal fashion in this, and we called them treatment supporters, which have been labeled previously in the literature, to support medication adherence and attendance to visits and so on. And so these non-physician health workers went through a 1-week curriculum. It was about 9 modules that they completed. We developed it here at PHRI, trialed it locally, and then obviously adapted it in Colombia and Malaysia for implementation. And again, these community health workers were supported by some mHealth technologies, which guided them out in the community. So they weren't all on their own after this 1-week session or training. So the HOPE-4 study itself, it was a parallel group, cluster randomized controlled trial. It involved 30 urban and rural communities in Colombia and Malaysia. And then the communities were randomized to usual care or a comprehensive cardiovascular disease risk detection and management program, as outlined by the 3 core components of the intervention. The study participants, in short, were essentially those over 50 years old with new or uncontrolled hypertension. So we primarily diagnosed as a systolic blood pressure greater than 140. The key thing about this study is it was community-based. We weren't picking patients out of medical communities. We were going door to door. We were going to social gatherings that were where participants would be present, and trying to do screening there to try to really capture those who weren't already ingrained within the medical system and being treated. And through that, we found 1,900 eligible individuals, and then 1,371 provided consent and were randomized to either control or intervention across the communities. We had 97% follow-up with respect to the primary outcome at 12 months. So just a few points before we get into the outcomes. I think it's important to note that we did have very high fidelity with respect to the implementation of our intervention. And so our non-physician health workers, as were labeled in our trials, but really it's exchangeable with community health workers and so on, really could go out there and demonstrate they could, with the support of the mHealth technology, could identify cardiovascular risk appropriately. They could identify contraindications to cardiovascular medications, and they could make treatment recommendations that were over 90% aligned with what the physicians who saw them and thought. We also found that, involving these treatment supporters, they were there at 94% of the scheduled visits. The participants attended 94% of the scheduled visits, and then the treatment supporters were there 74% of the time. And they're primarily family members, so this wasn't a complex kind of distant relatives or what have you. They're mainly people within their household. And we could see that the medication use was better. And so not only was it more appropriate in that they were using more than 2 antihypertensives, that was a higher number at 84% in the intervention versus control, and there's a greater use of statins in those group as well. But not only did they have access to those medications, they were also taking them with 50% greater adherence in this intervention group compared to control. So whether that's a culmination of the treatment supporters or whether it's a combination of the non-physician health workers or both. So looking at our primary outcome, which was the Framingham risk 10-year risk estimate, we use this as it's a composite of several different outcomes which we targeted with respect to our intervention. So blood pressure, cholesterol, smoking were key components. We didn't adjust for diabetes, as this study was not designed to try to prevent or treat diabetes other than through the lifestyle changes from a cardiovascular perspective. but we did demonstrate a significant drop in our primary outcome of almost 5%. And then when we look at that across all subgroups, it was consistent from across country, across urban and rural locations, men and women, young and old, and then higher and lower education. But I think what really stood out is if you look at the actual blood pressure control, and it was quite remarkably improved at 38% more of the participants in the intervention group were controlled as compared to the control group. And you have to remember our control group was actually an intervention in itself, because we were going door to door, identifying people with hypertension, letting them know that they have hypertension, giving them information on where to seek treatment, and giving them information about lifestyle changes. But that was the extent, and that was the control group. So you can see that's much more than what you'd get in its normal population. So we do think the effects are actually undercalled. If you look at the change in blood pressure, it was an absolute drop in 11 millimeters of mercury, and LDL was 0.4 millimoles per liter. If we look at some of the other outcomes, we can see that the trends were all in favor of the intervention group with respect to diet and some lifestyle factors. So in conclusion, with respect to this core study as funded by the GACD, we felt a comprehensive model of care led by non-physician health workers, guided by algorithms on a tablet involving primary care physicians and family, along with the provision of free antihypertensive drugs and a statin, substantially improved cardiovascular disease risk and blood pressure. We think that the success of the HOPE-4 led strategy was due to 4 key factors. One, we simultaneously addressed multiple barriers to cardiovascular disease risk. 2, we had a community-based intervention that was adapted to the local context. 3, we reinforced adherence with treatment supporters. And 4, we had a comprehensive intervention that kind of involved these computer-based algorithms to help guide these community health workers. So this was published back in 2019 at the completion of the study and presented at ESC at that time. But now I'd just like to kind of briefly go, and I realize I'm cognizant of the time, but where do we go from here? And I think there's just to touch on some of the international impact, and then what is happening in locally in Canada, where we were running the study as a base, and then in Malaysia and Colombia. So just with respect to our curriculum, and I think I'd like to say that I'm pleased that we were able to contribute and help with respect to the HEARTS technical package for cardiovascular disease. And that was some of the people involved in our curriculum development, including we're helping out with this development of this document. And that was a nice thing to see it through to a formal, obviously something that's used on the international stage. In Canada, we did adapt the HOPE-4 framework, and we looked at this. It was just published earlier this year in our Canadian Journal of Cardiology, but we addressed the same issue, and that hypertension just in high-income countries is still a huge issue. There's problems with detection, treatment, and control as well, and so we felt it needed to be addressed here. But we had a little bit of a different strategy, and we tried to work within some existing infrastructures within the Canadian landscape. And this was purely a pilot project, but some interesting things came of this. So one, we used firefighters in British Columbia, in Surrey, in the city of Surrey, where the firefighters were going door to door and doing home smoke alarm checks. And that's part of their duties, community outreach. And often they'd be going into communities that were lower socioeconomic status as the fire risk was greater. And so we thought, let's pair that kind of intervention, that community outreach, with screening for cardiovascular disease, using the same tablets, profiles modified for the Canadian environment for going forward and screening these individuals and getting them into the system to get their blood pressure treated and diagnosed. We didn't provide the drugs in Canada, as that is less of an issue, as they're either covered for those who need them or through private coverage. And then in Hamilton, it was through an urban core community center, where it's right downtown in an area where it's lower socioeconomic status, where there's a higher burden of disease. And so we use those two to kind of just implement this as a pre-post study design, and just a small group of total of 54 participants across the 2 cities. But while it is pre-post, not randomized controlled trial, it did demonstrate some of the similar findings as we saw in the larger study with a 16 millimeter drop in blood pressure and a 51% increase in blood pressure control. The outcomes at 6 months, it was truncate for this pilot study, but it was similar. We demonstrated a benefit in risk score as well. This is the last step, and obviously this dovetails nicely with the presentation that was just given. And this is something that one of our PIs in Surrey is now the research director for the National Indigenous Fire Safety Council, and just approached us just recently to consider kind of thinking about, can the HOPE-4 framework work within that community? And this is very early days, and if I were to kind of take from the presentation before, that with the River of Wisdom, this would be essentially, we're still in that very first phase between idea to kind of proposal, where we've just kind of at the stage of presenting that. And so I look forward and excited to see if there is any interest in how something could be developed. So that's kind of where we're at with respect to things in Canada. I will take a pause and just mention in Malaysia, and in memory of Professor Khalid, who was our principal investigator out in Malaysia and did wonderful work with us, and obviously wonderful work in the area of cardiovascular disease research, health services research. He passed earlier this year, and I won't speak to the kind of, he was making wonderful inroads with respect to the government and policy and actual implementation of some of the HOPE-4 framework in some communities. But I won't go into that at this stage right now, but did want to give my respects to Professor Yusoe. I'm not sure if Patricio's joined, and if you have, then please jump in, because Patricio has done is doing wonderful things across Jamaica, Colombia, in collaboration with Spain. So I don't hear that he's there. So
I don't see him.
Okay, I'll speak on his behalf, and we did prepare for that. I think there was going to be some concerns, but Patricio has 3 separate projects now, building off the HOPE-4 framework with the similar concept of the community-based strategy to deal with hypertension treatment and control. And this is, so in Colombia and Jamaica, he has a project that is now funded where he's implementing and scaling up this team-based care strategy. He also has this happening in the Santander district in Colombia, and this is implementation, integration, and institutionalization of a community-based care program to reduce the risk of cardiovascular disease. And this is again built off that framework that came out of the GACD. And then finally, he has a third project, the COTRACO, which is use of an innovative community-based model for the management and follow-up by non-medical health personnel to improve the awareness, treatment, and control of arterial hypertension. So these 3 projects that are implementation projects out in the community have obviously springboarded from the collaborations that we had through the GACD project and HOPE-4. So I'll stop there, and I did hope that was not too long. And thank you very much for giving us the chance to participate and present today.
Thank you very much, JD. That was an excellent presentation. You didn't go on too long at all. You actually kept the messages really on track there. And I would like to say thank you. But first of all, I'll ask if there are any questions from the floor for our speaker. If you want to raise your electronic hand or turn on your camera and speak out, then please do so. Perhaps I'll ask a first question. JD, what does it take to actually, move this, get the evidence from your outcomes into sort of policy and practice? How do you build those relationships?
Yeah, so I think I can speak to the challenges in Canada, and but I think one of the things, the inroads that were made in Colombia and Malaysia following the study were outstanding, and I think it speaks to our principal investigators there, both Khalid, Yusoe, and Patricio. They have the they've built that kind of, we call it integrated KT, or integrated knowledge translation, where right from the get-go they involved key policymakers. They knew about what was happening with the study. They were interested, and so they were kind of keeping tails on the results of the project and as it was coming along. And so it wasn't a kind of starting from scratch once the results were there. So I think that was a key thing that helped them kind of implement and continue this implementation in communities. I mean, no, it hasn't been scaled at a national level, and we won't say that, that's a challenge, but to continue the implementation in certain communities that they found were most beneficial happened because of these relationships that they had throughout the development of the project and through to the end. So I think that's key.
Yeah, that's great. Any other questions from the floor? I don't see any hands going up. I mean, I just say that was a very clear presentation, and it's clear why the HOPE-4 study has been one of the case studies that our independent reviewers actually agreed really outlined the pathway from research evidence through to practice and policy. And I think that's been an excellent presentation.